Good afternoon, and welcome to the 360DX virtual roundtable discussion entitled HIV Molecular Diagnostics in the PrEP Era. I am Madeline Johnson, a reporter at GenomeWeb and 360DX, and I will be your moderator today. We would like to thank our sponsor, Hologic, and acknowledge their support of World AIDS Day. Please see the resources available for download on the left side of your screen. I am honored to present our esteemed panelists for today's discussion. Dr. Keith Jerome, professor in the Vaccine and Infectious Disease Division at the Fred Hutchinson Cancer Center. Dr. Antonio Urbina, medical director of the Mount Sinai Institute for Advanced Medicine, 7th Avenue Clinic, professor of medicine at the Icahn School of Medicine at Mount Sinai, and medical director for the Clinical Education Initiative of the New York State Department of Health AIDS Institute. Dr. Rupa Patel, infectious disease physician and voluntary research associate professor in the Division of Infectious Diseases at Washington University in St. Louis, and Dr. Barbara Van Der Pol, a professor of medicine and public health at the University of Alabama at Birmingham, and the director of the UAB STD Diagnostics Laboratory. Welcome, everyone. To all of our audience members, thank you for being here, and we hope you will find this conversation stimulating and enlightening. We welcome your questions and aim to set aside the last 10 to 15 minutes of the hour for a Q&A. You may type in a question at any time during our roundtable event through the Q&A panel, which appears on the right side of the roundtable presentation. There are additional widgets you might find helpful to enhance your event experience. You can find these on the bottom tray of your window. And now, let's begin our virtual roundtable presentation. So just to make sure we're all on the same page, I want to review different types of HIV testing. Dr. Van Der Pol, could you please remind everyone what these are and when they're typically used? And I'll pull up a slide here that might help.
Hi, and thanks for the introductions, and it's really a delight to be able to be here. World AIDS Day is particularly relevant, I think, for those of us who have been in this field for 30 or more years, watched HIV come and ravage many populations, but knowing we're at a point now where we have a lot of control over this infection. And so it's a really exciting time to talk about this. But again, as Madeline just said, just to try and make sure everyone is on the same page, the major types of diagnostics are shown on this graphic. And the one that we're all the most familiar with is the HIV antibody test. This is often done as a rapid test at the point of care where patients can find out the information right away. And there is one test that has clearance for use in the home by the patients themselves. As you can see from this graph, though, HIV antibodies do not become positive or detectable by these tests until up to 3 or 4 weeks after initial infection. So that's what we call this diagnostic window, where we can't necessarily take a negative test result and assume that that means the person's not infected. So a little bit of caution needs to be used when using antibody tests to really understand when the person thinks they might have been exposed, because that drives what kind of test makes the most sense. The next kind of test that became available for us was the P24 antigen-based test. The antigen is circulating in the blood a little bit earlier than the antibodies, and it helped us reduce that window down to about a 2-week time frame after exposure or after onset of infection. But this is still not the most sensitive sample type. And what many tests have done that are run in the lab now, or they're now combo tests that are antibody and antigen, to all run from patient serum, but can quickly tell you either of those two to try and, again, maximize our opportunity to catch infection early. But the most sensitive sample or type of testing that we have right now is detecting RNA of the HIV. And we can do this much earlier on, as early as 5 to 7 days after onset of infection, because that's when viremia starts and there's a lot of organism circulating in the plasma. And so that can be detected easily with lab-based tests. Most of the HIV RNA tests are lab-based, although there are a few that are becoming more readily available that are near a patient. But usually these have to be sent away and done sometime in the lab, with results coming back within 2 to 5 days usually. So that's basically what we have. Some tests that are very rapid but not quite as sensitive, and some tests that are hypersensitive but not quite as rapid. So there's always a little bit of a trade-off. And I think throughout the time period of this webinar, we'll talk about advantages and disadvantages of using these tests at different times for different.
Fantastic. And speaking of trade-offs, Dr. Jerome, I'm hoping you can remind us about predictive values of these tests and how that changes with prevalence, and kind of why that's important for test selection. Dr. Jerome?
Yeah, so as I think hopefully most are aware on this webinar, there's no perfect laboratory test, and that is what fraction of they detect and how often do they give us an erroneous. And there are trade-offs with these tests. All these HIV tests have been developed over many years and have been quite optimized, so they do perform quite well. Now, the most sensitive test which can
Dr. Jerome, I think you're cutting out a little bit. I'm sorry.
And the possibility of false positives. But you, I'm sorry. There are better. At least pretest probability of infection. Population would be the prevalence of infection within a population. So positive result in the context of what the likelihood is that that patient had the infection before you went into things. So a great example that people often use are tests for prostate cancer. If you gave those to 100 pregnant women, you might find a positive, and yet you know that that's false positive, simply because the pretest probability is essentially zero there. And so in populations where there's relatively little chance of HIV infection, it's very important to look very carefully at positive results and typically confirm those or take those in the context of everything at all. So throughout the discussion today, we'll be talking about the various scenarios in which we test patients, particularly those who are contemplating or are on PrEP. And it's important, again, to interpret any test result in the context of the entire clinical presentation.
Wonderful. Okay, thank you. Thank you both. So the CDC estimates that 1.2 million people in the US are at a high risk of HIV exposure and could benefit from HIV prevention strategies like PrEP. And I know PrEP in a pill format was approved in the US in 2012, and an injectable format was approved last year. So I'd love for our clinical care experts on the panel to tell us a bit more about what is PrEP. Dr. Patel, could you tell us how do the different formats work? And then Dr. Urbina, maybe you could jump in and say, like, who is using PrEP and how would increasing its adoption be beneficial? Dr. Patel?
Yeah, thanks, Madeline, for that wonderful question. As you had said, when we look at PrEP and the types of PrEP today, we can break that down into oral PrEP or injectable PrEP. When we say oral PrEP, this is a pill that's taken by mouth. 2 medicines are in it in a fixed dose combination. And so we can have daily oral PrEP that's taken every day. We've got, I'm going to say types, but even 3. So in general, the first one that came out was branded as Truvada and then went generic. So people in the audience, providers, testers, community members, you know, there's the Truvada, which is a blue pill and branded as M-tricidabine and dofavir, bisoproxyl fumarate. And then the generic version is a white pill. And the two medications would be labeled when you get your prescription. Kind of the third option of the two different types of medicines, but in different pill formats, is another one called Descovy, branded as Descovy. It's a smaller blue pill. It has tenofovir and it has tenofovir, alafenamide, and M-tricidabine. So after we've gone through the oral PrEP, within oral PrEP, there's also, it is not FDA approved. It is mentioned in the guidelines. We have 211 or on-demand PrEP. You can take the medications I described above, M-tricidabine and tenofovir, and it's basically taken in the format of 2 pills on the same day, and then 24 hours later you take a pill, and then 24 hours after that you take a pill. So the same day of a sexual encounter, you take those pills, and then 1 and 1 thereafter. And now moving to injectable PrEP. Injectable PrEP was recently FDA approved. It's cabotegravir. It's an injection every 2 months after you've received your loading dose of 1 injection every 30 days for a total of 2 injections. So that's a summary of today's PrEP products. And I'll pass it over to Dr. Urbina.
Yeah, Dr. Patel, that was a fantastic explanation. And I think what she's highlighted is that there's just a lot more tools now that providers have to offer patients prevention against HIV, and that's great. So I do think it's scaling up. I think Madeline gave some stats that only about 25% of what they estimate to be the 1.2 million persons that are eligible for HIV just based on risk factors for HIV acquisition. Only 25% of those patients are on PrEP. And kind of what the CDC and the National HIV Strategy Plan is, they really want to increase that number to 50% by 2030. So I think in order to do that, we really got to find ways to scale it up and have a lot more community engagement. Now, of the persons that are on PrEP, the majority of them are men, and the majority of them are white men, white gay men. So although white gay men, do account for a sizable amount of new HIV infections, I think really where the epidemic, where we really need to scale up PrEP are in young Black gay Americans, young Black women in the US. And I think all of us are kind of struggling with how best to do that, and how do we get community engagement, how do we get buy-in, how do we equitably take these newer forms of PrEP, like what Dr. Patel was saying with the long-acting injectables, into these communities.
Amazing. Okay, fantastic. And then, so now we know about the different kinds of testing and the different kinds of PrEP. So integrating those two, at what points in a PrEP treatment protocol do people typically get tested for HIV? Dr. Van Der Pol, could you sort of start addressing that one?
Well, so it depends obviously which type of PrEP you're receiving, but if you're receiving the oral PrEP, and it's generally recommended for testing every 3 months, which is what the prescription length usually is for those oral medications. The injectables are every 2 months, so obviously they've moved that back to testing every 2 months. And there's some flexibility and some wiggle room in the guidelines, and so people test for PrEP more frequently, or test for HIV more frequently or less frequently, depending on how their patients are doing. But those are the general guidelines.
Okay, super. And then I know there's some possibility that a patient could develop resistant HIV if they're exposed to like a low dose of PrEP and then acquired infection. So I was hoping, Dr. Jerome, could you sort of walk us through this graph of showing like at what point is there this risk, and sort of what can physicians and laboratorians do about this window?
Sure. So it's important to understand that PrEP is typically highly effective. And for patients who adhere to their PrEP, first of all, infection is rare. And certainly the development of de novo resistance is very rare in those patients. There's another cohort of folks who really have quite poor adherence to PrEP. This group can experience infection. And typically, resistance is not common in this group simply because most don't. That have times where they miss PrEP and have the unfortunate possibility of getting infected then. But the big risk that we actually see and work hard to avoid in the laboratory together with our clinical colleagues is to avoid starting patients on PrEP during that window period that Dr. Van Der Pol discussed, where a patient's infected, but we just don't see it yet through laboratory testing. And that's why the recommendations are typically to do the test within a week of starting PrEP, to minimize that, and it's really as close to the start of PrEP as possible with the most sensitive assay available, which is typically a 4th generation antigen antibody test, to really avoid those. Now, people who get infection during that time can be at risk for developing resistance because they're basically on a infection. So those, we really want to avoid those and end infections as early as possible so that people can be transitioned over to an effective antiviral regimen.
Okay. Does anybody else have any comments on this?
If I can jump in here, I think one of the things that we have to, there's a couple pieces here that are really important, I think, when we think about testing for HIV with people on PrEP. The first is that it may be that, as you know, Dr. Jerome just mentioned, that using the most sensitive test right now is often using the 4th generation, which is the antibody antigen combined, which just gets us down to, you know, within about 10 days after onset of infection or exposure. But it may be that there's enough advantage to using viral load testing, whether it's quantitative, it doesn't have to be viral load, but a quantitative or a qualitative RNA test, because the sensitivity is substantially higher. And so if programs have a population that they know that they're serving, where they know that there is resistance in the population, and so that means that resistant organisms could be transmitted within that population, perhaps in those settings, it's wiser to use an RNA-based test rather than a simple serology test. And it does add some cost, but it's still probably in the long run, when you think about the cost of resistance and managing, putting people on second-line therapies and so on and so forth, I think that there may be a benefit to that. The other thing to remember is that, you know, the resistance isn't driven by people not taking drugs per se. What happens is when drug regimens are not quite at 100% effectiveness is when they're not adhered to completely. And they don't necessarily cause mutations in the organism, but what they do is they allow those minority populations of resistant bugs to become the majority population, right? And so it's this shift. So it's not that we're causing the bug to mutate per se, as much as if, again, you're in a population where you know that resistance is a problem, this is something where you have to be much more vigilant among that group of people. And by populations, remember, I'm not just talking sort of generically, so we can't say that the population in a city or the population even in a clinic, but it may come down to more specific factors about what that individual's sexual network and so on looks like, because then we can understand better their exposures, and then we can be more rigorous in adhering to guidelines about frequency of testing. I think one of the things that has happened, especially because of COVID, it became a little bit difficult for people on PrEP to access services, you know, on a really strict schedule. And so while we can mail people prescriptions, we also still have to think about the testing, right? And so we can't let that fall by the wayside. And I think that's why we've put together this kind of topic that's sort of multi-pronged, right? Where we're talking about PrEP and we're talking about diagnostics, because really it's important to make sure that we have all the support services that people need so that PrEP is effective.
Excellent. Okay. And you're mentioning molecular testing, so I'm wondering, kind of for all the panelists, it sounds like there are some cases where you would want to have molecular testing earlier, more frequent, focuses on that. But then we mentioned earlier that there's, can be a delay to get the lab results back. And I imagine that's a trade-off that you're all sort of facing. So I'm wondering if you could tell me when do you order the tests, or when is it typically like the standard of care in your area to have molecular tests? And I think, Dr. Patel, can I start with you for this one?
Yeah, this is a great question, and sometimes the holy grail when you're sitting in a primary care center and there's so many HIV tests to get and you're confused. So the molecular test, just to clarify for everyone, is that viral load or RNA test. And there, Dr. Van Der Pol I'd mentioned there's a qualitative and a quantitative, and I think that's important to establish. The quantitative gives you that viral load, actual copies. Qualitative gives you the detection. And there are price differences between qualitative and quantitative. The quantitative is double the price than qualitative when you're looking at CMS dose pricing. And that's important because, we have thousands of patients we're getting testing for, or, an insurance of a patient is being billed. So in general, going back to the question of when do we get this test, I think first and foremost, all the panelists can agree we're definitely getting this test when we suspect acute HIV. When someone has had exposure with or without symptoms, and we really want to have a tighter window period, meaning within 7 days, can we detect that somebody has HIV, because that window period is longer with antigen and antibody testing, at least 2 weeks. And so typically in standard of care, just when people are coming for PEP and PrEP, we're looking at exposure, acute HIV, getting this test when needed. Now I'll transition to PrEP care and initiation and the guidelines and follow-up. The guidelines of the CDC from 2021 December have instilled molecular testing when you initiate PrEP, and every 3 months if you're on oral PrEP, and when you initiate PrEP, and every 2 months when you're on injectable PrEP. I wouldn't say that these guidelines are adopted widely by every clinic because of cost and billing, et cetera, related to patients' kind of out-of-pocket costs. I will tell you in my clinic and many other clinics, for oral PrEP, we are not using molecular testing every 3 months just because of the sheer cost that has been a burden on clients and their insurance. There has been a move to talk to LabCorp and Quest about, special billing and coding and modifiers so that the molecular testing in the name of PrEP is considered preventive care. But this is just something some people need to think about. And then I think what's also very important is with cabotegravir, there's been a handful of cases, cabotegravir used as HIV prevention. There's been a handful of cases where we had delayed diagnosis. So I think many of us who are administering Apretude, the brand name, or cabotegravir long-acting injection are getting that viral load testing every 2 months. Just so we don't miss a delayed diagnosis of HIV while someone is taking this long-acting medication. And again, it's very important that that's worked out with insurances, et cetera, because the viral load testing is a substantial amount of money. If you went from no testing and you were a PrEP patient last year, and then now this year, all of a sudden, you have a new protocol in place with the CDC. And I'm going to go ahead and turn the mic over to Dr. Urbina from New York. He can tell us what's going on there.
Yeah, so I think you explained it really, really nicely in that the CDC updated their guidelines in 2021. Dr. Patel makes a very important point is that, being on these prevention medications, oral, but actually more with the long-acting injectables, is that being on these antivirals can delay the detection of these standard antigen antibody tests, as Dr. Van Der Pol explained really nicely, so that you may miss infections. And these tests may be delayed for 3 months or maybe even a little longer. So there's a risk there. If you delay detection, just maintain someone on this PrEP and they seroconvert, there's data to support that you have a greater likelihood then of inducing mutations and actual resistance. So I think the new standard of care, in particular for long-acting cabotegravir, is that we get these viral loads not just prior to start, but at each of those subsequent injection visits as well. I think Dr. Patel brought up a great point, which I think we're going to address later in terms of cost, because that first year that you're on long-acting cabotegravir, I think that's 7 viral loads, molecular tests, because you have a baseline. Then at Sinai, we do another one in a month, and then every 2 months, and then subsequently 6 a year. We also don't uniformly do molecular testing for those stable on oral PrEP just because of the costs. We definitely try to do it when we onboard patients. But again, here, I think that clinics and hospitals are going to have to come up with protocols and best practices for how to implement molecular testing with these newer technologies. And not to jump the gun, but now we have long-acting cabotegravir, which is every 2 months. But there's also going to be subcutaneous lenacapavir for prevention, subcutaneous injection every 6 months. But again, the frequency of these molecular tests really do have to be incorporated. And I think that's a challenge with our healthcare system. Is it public? Is it private? Commercials, copay, coinsurance? So I think we're all kind of grappling with that. But I do think it is the standard of care and the best practice to incorporate molecular testing.
Okay.
And I might just add in that I know we're not really talking about, everybody's sort of dancing around cost. But the reality is that one of the reasons that RNA-based testing is quite as high as it is because there's not a huge volume, right? And because when we get them in the laboratory, the way these tests are set up, if you don't run at least 24 at a time, you lose money because you have to throw away a lot of product. So, and those are just, ballpark numbers, and it varies by the assay that you're using. But so if you're in a smaller setting and the only time you're doing RNA-based testing is to confirm after people have gone through the serology algorithm, then you might not ever have enough of those tests to make them cost effective. But as volume changes, because we're using that test more frequently for more people, hopefully that can drive lab prices down. But the other piece of that is what you just mentioned, and that is that we really have to think about how do we approach getting reimbursement operationalized so that people are paying much less out of pocket.
And in your, what is the standard of care where you are for molecular testing?
Well, we do molecular testing for our people on PrEP, but that's because we have kind of an unusual support system here because of the different work that we do and ways that we can find to cover those costs. But we know that we're kind of a different situation, right? We're not relying entirely on insurance. So.
Okay. And Dr. Jerome, where you are, what is the standard of care?
I think we're sort of similar to Dr. Van Der Pol in that we have been big believers in molecular testing so from the beginning, and our system at the University of Washington tends to move or favor molecular testing when there's really the scientific basis for it, and I think that's been really nicely described here, the importance of early detection. And I'll just reiterate that point from a virologist's point of view that these antigen and antibody tests, when people are on PrEP, we say the diagnosis is delayed, but simply because the virus is partially suppressed, and similarly the generation of the antibody response is delayed as well. And so the molecular testing really becomes especially valuable in that setting.
So interesting. Okay, thank you. And then, relatedly, it sounds like the guidelines have changed, but has anybody seen any changes in lab testing volumes yet? Or is that something that we can alert our audience to look out for that might be coming in the next year or two? Dr. Van Der Pol, could you tell us, like, are you running more HIV viral load tests than you used to 2 years ago?
No, we're not running more, but again, as I mentioned, because we're a smaller setting, we've been able to offer that service for quite a while. But I think in larger settings that don't have alternate funding mechanisms, I think it might be a question of how quickly they're seeing the changes. I think maybe the folks at Mount Sinai have more thought and input into that than I would. Okay.
Dr. Urbina.
As soon as the long-acting CAB reticulovir was approved, we kind of alerted our laboratory directors about the potential for increase in volumes. So they were kind of made aware very early on that there could be this scaling up. So I think that they were kind of prepared to do that within the Mount Sinai Health System. I believe they're using the Roche PCR platform. So they've always been able to batch them, and I think also just to help with costs. Remember, we're also using these testing technologies for people living with HIV, and I think they're using similar platforms for both PrEP patients and also for those living with HIV. And we haven't really scaled it up quite just yet. A lot of that has been just because of the infrastructure of just scaling up long-acting PrEP. So it's not just the diagnostic testing, but it's making sure you have enough nursing staffing to actually do these injections. And that's been our pushback from nurses, like, hold up, back it up. We don't have the staffing right now to scale up these long-acting injectables within our system until we really look at our infrastructure and our staffing needs. So that's what's kind of been holding us back, to be quite honest.
Okay. Okay. Dr. Patel, do you happen to know if there's any increase in volumes in your labs?
Yeah, definitely after the guidelines came out and also cabotegravir came out, we have had an increase in obtaining the viral load testing. And I think the first thing was operationalizing billing and understanding if the at the patient level, the insurances were covered so that we didn't have surprise out-of-pocket costs and bills for clients. Just, that would affect consumer satisfaction and also make PrEP very difficult as an entity for them to take. So I think in general, we've seen an increase, but as all the panelists have said, I think there's a lot of work to do to get the system working. And that does include talking to your lab, your billing components, your billing stakeholders, and then the patients themselves, warning them, telling them about bills to expect, et cetera. So it really has to be a multi-stakeholder kind of effort.
And I think the other piece of this, when you're talking about lab volumes, is that there is recommended STI screening as well. And again, we've had a lot of pushback from PrEP users to say the guidance is a little waffly on the STI testing, and it says every 2 months for injectables, and it says every 3 to 6 months for the oral, and I'm not sure why quite the difference. But anyway, it's there, and again, not a lot of people are adhering to it at this point. But for labs that are doing molecular testing, they're likely, if they're doing HIV molecular testing, to also be doing STI molecular testing. And so one has to think about the potential for increase there. But the pushback we're getting from patients is that it's huge amount of expense out of pocket because insurance refuses to cover it, especially if you're looking at people who need testing at multiple anatomic sites. There can be as many as 3 STI tests per patient. And if the patient is paying for those out of pocket because they're more frequent than their insurance wants to cover, it can be several $100s. multiple times per year out of pocket. So, I mean, you know, the whole thing is a big package. And so I think that, you know, as was just said, it's a multi-stakeholder process, and a lot of people have to be at the table if we want to make this work.
Okay. And just to be clear, I mean, the people that are engaging in this process, they are currently well, right? They're going to agree to get tested every 2 to 3 months with all these different tests to do this prophylactic treatment to keep them well. But yeah, I imagine that it would be a challenge to sort of get them to commit to that number of times going to the doctor in a year.
Well, I think that there's a couple things. First of all, the treatment's prophylactic for HIV, but does not protect against STIs, obviously. Yeah. And one of the things that often happens when people are on PrEP is that they may engage in condomless sex. And if that's the case, then their risk of STIs is increased compared to when they were on or off PrEP and they were using condoms. So there is, again, this trade-off. And I think many men who are on PrEP are okay with having the testing done for STIs on a routine basis. However, there's a super lack of convenience if you have to actually go into a clinical setting. So people would like to be able to collect specimens at home and mail them in. You know, that sort of option, and the same thing for the HIV testing. In fact, you know, COVID showed us that people can collect their own samples and either test at home or send them in, depending on what, you know, the pathogen is. But we have the capacity, and now people are aware that we have the capacity, and they want that opportunity and that option. But again, it has to be covered by insurance, or people, that's where the stumbling block comes in, is not people being unwilling to test, but people being unwilling to pay.
Okay, fantastic. Let's see. Dr. Jerome, I think I didn't ask you what the standard of care is where you are.
I think you did. I think you didn't ask about our volumes, actually. What we
didn't. Okay, sorry.
Yeah, so we definitely saw an increase in as the other panelists pointed out. We knew that might be coming. I will say that it was the least of our worries in terms of volume increases over the last couple of years, given the COVID pandemic. So this almost was just a ripple in the waves, at least for a laboratory that was doing both of those tests. And one benefit, if we can call it that going forward, is of course that there are common platforms that obviously can be multiple pathogens. And so I believe there's likely to be additional installed capacity in many of the labs we're talking about, and hopefully we can put that to use, and we certainly have in our case for a test like this.
Fantastic. Okay. Our sort of final topic that we can talk about in the remaining 10 minutes or so is this equity piece, which sounds like it's partly related to the reimbursement and cost piece. I took a look at the strategy document that Dr. Urbina mentioned, the White House National HIV/AIDS Strategy 2022 to 2025, and it calls for expanding PrEP, which in turn would presumably increase the need for HIV testing, and again notes what he had mentioned, that about a quarter of people who are sort of it would be nice if they were on PrEP because they're at high risk. There's only a quarter that are actually on it, so it would be good to increase to say 50%. But the inequities, it sounds like, are by race and geographic area, are maybe even getting worse. That there's some communities where the risk is higher and they're less likely to get PrEP as in the last few years. So I wanted to ask you all about technologies or approaches that might help with different communities and different geographies, and also sort of anything that can be done about cost or reimbursement. And Dr. Patel, I'd like to start with you in New York, but Dr. Jerome, you're in Washington State. Sorry, Dr. Urbina in New York. Dr. Patel, you're in Missouri. Dr. Van Der Pol in Alabama. You guys represent like the four corners of our country. So please tell us, like, you know, what is the equity issues where you are, and how might these be addressed maybe with technology or other sort of approaches? So Dr. Patel, please.
Great. Yeah, I think this is a wonderful topic and a great topic to end kind of this didactic portion or panel discussion portion. You know, in general, I think for PrEP, because we have to meet the needs of the client, and PrEP is among several of the priorities a young adult has, besides putting food on the table, getting to work, having transport issues. So we have to make a menu of options to get PrEP. So there's definitely in-person PrEP. Come to a clinic if you want to see your doctor. But then, you know, COVID and even pre-COVID, we were designing tele-PrEP. I think one thing I want to let people know in the audience is if you're designing teleservices, I think it's important to address digital poverty and make sure, you know, there's the equipment and the internet bandwidth that you need in order to connect to an electronic medical record or platform in which an office visit happens. And, you know, Dr. Van Der Pol had said during this discussion as well, you know, we have to have the testing. If someone is remotely obtaining services, then we need to make sure the labs are getting to that person, whether that's a lab around the corner from their home, like Quest, LabCorp, or any of these commercial entities, or it's the kit. We've seen PrEP at home, molecular diagnostics, other kits that you can self-collect at home and send in. Following up on that is more challenging. So that you need to have the staff resources to make sure the kit went okay and someone knew how to mail it out, etc. And then, you know, there's, you know, different delivery methods of PrEP through community-based organizations, mobile vans, you know, other public health, you know, state and local government entities and clinics. So I think there's a wide variety to have, you know, it's important to make a wide variety of access. And we did that in Missouri, and we've learned from around the world. And I'm going to pass the baton over to Dr. Urbina to tell us what New York State's doing.
Yeah, no, those are all really important points, and just kind of lowering the threshold for patients to access these interventions and to be able to do testing, and that it's not too restrictive. I think those have been some of the things that we've been doing here in New York City to make it more patient-centered. I do think one of the very important things is that regardless of the greatest technologies, they're only as good as like the systems that are in place to equitably, you know, distribute them so that everyone has an equal chance of accessing these medications. And I do think that a lot of these interventions could be scaled up by like going local, going to your community health centers, going to these areas that are maybe not traditionally known as being where HIV patients are seen, but more kind of general primary care. And the other thing, and I think this is also a switch that the CDC is really to make our conversations more kind of sex positive. Mm-hmm. So, you know, incorporating PrEP as an intervention to, you know, improve, enhance sexual health. And like I think as Dr. Van Der Pol said too, you know, when you talk about PrEP, you also open the window to talk about sexual health and sexually transmitted infection. So I think kind of changing that dialogue too, I think we'll be able to engage more populations. But I do think it's something, it's very public health, and I do think you have to go within communities and really build trust and to not make it too cumbersome.
Okay.
If I can jump in, I think the two things I would add to that is jumping right off of what Dr. Urbina just said, and that is trust. And I live in the Deep South, and there is an enormous amount of medical mistrust because many of the researchers and providers in this area decades and decades ago behaved very, very badly, and people have long memories. And this is especially related to people of color and to sexual health issues. So we are still dealing with the fallout of that bad behavior, and we have to recognize that we are in that environment, and we have to make sure that everything that we do is the highest possible quality, and it's done with complete transparency. And I think, so that's just where we, at least here in the Deep South, have to start. But the other thing to equity is recognizing that, as Dr. Patel said, we need a toolbox with lots of options. We've done research with patients or people, I should say, in communities in Alabama, and in focusing on Black women in Alabama, we find that people living in urban centers, like where the university is housed, feel completely differently than people living in more rural areas. They want different types of contacts. They want PrEP to be offered by different types of providers. They want different options, whether it's picking up their own medications, having medications mailed to them. We think about mailing medications, and we think about telemedicine and mailing collection kits for sample collection, but we have to remember that not everybody has complete privacy. Just because something's mailed in a brown box doesn't mean someone else in the household doesn't open that box. Mm-hmm. And so then all of a sudden your privacy is completely gone. And so we have to be really mindful that what sounds simple requires a little bit of thought and a little bit of understanding the context in which people live. And I think the more we take that into account, the more we're able to rebuild the trust that we had broken in the first place. The other thing I will say about trying to get PrEP out to people, obviously there are stigma issues, because the reason that young men of color who are gay are at such risk of HIV infection is because they don't seek services, because it's still so highly stigmatized that we are not as accepting as we should be of sexual and gender minorities. And you can't make the population at whole and society at large turn off their prejudices, but we can do everything we can to combat those. And one of the things that I would really argue is providers' attitudes are so very important. And there's some language in some of these recommendations that say, if someone asks for a test, you can give them a test, or if someone asks to be on PrEP, you should discuss it with them. Well, I would argue no. A provider's responsibility is to drive the conversation, and the provider needs to get over the stigma, and they need to initiate this. Is there any reason that you should be talking with me about PrEP? Are there things you want to tell me that would make me think that PrEP would be useful to you? Are there things that you want to tell me that say, I should maybe offer you sexual health screening today? But until providers become comfortable initiating the conversation, if they're waiting for patients to do it, we are never going to get out of the hole that we're in. That's my soapbox.
Okay. Dr. Jerome, I'm just so we get to hear about your corner of the country before we go to Q&A.
Sure. So from the point of view of the lab, I love the idea of us trying to provide the frontline providers with as broad a toolbox as possible. And some of that we have seen through COVID, the addition of a number of point-of-care platforms that can provide highly sensitive and affordable testing. And that's going to pay some dividends in settings like this going down the road. We have a very rural population in the eastern part of our state, and so these are issues that are very important to Washington State. We have been doing a study for several years on our hematopoietic stem cell transplant patients following their CNV levels remotely using self-collection of blood, and in this case, dried blood spots. And I would say that patients love it. They love not having to interact, not to go to the blood draw as often, to space out those meetings with their healthcare providers. And so if we can provide people the option for high-quality telehealth when appropriate and high-quality testing, I really do think we're going to take the best care of our patient population that we possibly can.
Fantastic. Okay. And I think we have to get to the Q&A, but I have so many more questions for you all. But we will allow the audience to ask some questions here. let's see. We'll now open the Q&A for the remaining 10 minutes. As a reminder, please enter your questions in the Q&A panel on your screen. We'd also like to ask attendees to take a moment after the event has ended for a quick exit survey to give us your feedback. And our first question, let's see. Someone asked, can you comment on new USPSTF guidelines in the works? And do you think that they are going to recommend molecular diagnostic testing? Does anyone have a thought about that?
I mean, I think they're going to follow the CDC recommendations in terms of molecular testing for PrEP, in particular with the expansion of long-acting injectables. So I think that that'll just subsequently follow. I think that that'll be helpful in terms of like championing for reimbursements or any cost issues if the USP, if that organization makes it a formal recommendation as well.
Okay, and one of the audience members asked if testing for PrEP users is so crucial and cumbersome, would you recommend at-home or self-tests for users to do at home and report results to their providers? And I imagine those would have to be the antigens.
The only test that's approved for at-home use by individuals is an antibody test, and it's not the most sensitive antibody test out there. So the reason why it would be better than no testing, so like during the COVID sort of event, I mean, it would make some sense, but you really want to use the most sensitive test that you can use, because remember, these are people that you said 3 months ago were negative for HIV. So you're testing in what you consider to be a known negative population. So we're looking for incident infection, which means that infection is going to be recent and rare. And for those two reasons, you really need the hypersensitive lab-based test if you can get them. But is doing an at-home test better than no test at all? Sure. But what I would suggest is home collection with samples then going to a laboratory to utilize those highly sensitive tests in the lab, but without the patient having to make an in-person visit. So we can do home collection, but home testing is still not quite ready for prime time.
And that actually kind of feeds into one that I had, which was sort of the way that COVID had, the pandemic had sort of changed everything with telemedicine. I mean, this is infectious disease testing, so you would like it's reportable to public health, you know, so that sort of reportability seems like a really important piece for any home testing, I would imagine. Dr. Urbina, did you see a lot of changes in the pandemic? And did Sinai do telemedicine with any patients or?
No, definitely during the pandemic. And I think the national data saw like about a 17% decrease in new infections. But I think that was due to lack of access, lack of coming in for testing. So I think we're now starting to see that during COVID, I mean, people were still engaging in behaviors that may have led to transmission, but they just weren't getting tested. So we're starting to see those patients now in our clinics. Definitely, a lot of us utilized telemedicine during that time, but I think that during COVID, there was just difficulty with access for patients for getting in. So we really did rely on kind of telemedicine, and we kind of utilized, I think a lot of the things that we're talking about is like lower barriers to for patients going to like a laboratory to getting their, HIV testing done. We did try a little bit of the home testing. That again was like limited, and I think what Dr. Van Der Pol said, not on the best test, but better than nothing. So I think now that things have changed a little bit and there's been more access, I think patients are feeling much more comfortable coming into the offices, getting tested here, sexual health screening and all of that stuff. But we did see that initial decline. But I think that was due just to patients not coming in, not feeling safe.
Okay. Somebody had a very specific reimbursement question about the quantitative HIV-1 viral load tests are the package insert says FDA cleared package insert says they're for individuals who are known to be HIV infected. So from an insurance reimbursement perspective, how do you handle insurance blocking those tests because they are being used for screening instead of testing a person who is known to be infected? Has anybody encountered that?
Well, it happens.
Madeline, go ahead.
Yeah, go ahead, Dr.
Barbara.
Go ahead.
Oh, yeah, no, I think in general, this goes back to your first question. It's, what do the CDC guidelines say and what do the U.S. Prevention Task Force guidelines say? And, you have to bill it as PrEP and preventive medicine or preventive encounters. And then the insurances should cover the HIV viral load test in this context.
Okay.
Yeah, and then just quickly, because we now have to all become billing experts as well, is there's this modifier like for like New York State, I think it's modifier 33, and that kind of signals that this is a prevention visit and it should cover all diagnostic testing, including molecular testing.
I love that. Okay. And you had mentioned before too, I mean, is New York State unique in its coverage of PrEP and testing?
I mean, maybe a little bit in that I think with our AIDS Institute, and we do have this PrEP app program, which is a state-funded program that will allow us to cover costs for PrEP-specific services for patients that are not insured, underinsured, immigrants. So we do have this state funding program to cover vulnerable populations.
And some of our audience had questions about qualitative versus quantitative tests, molecular qualitative versus quantitative. I'm going to ask one of our lab experts here. Is there utility for a qualitative molecular test, or just sort of the viral load so low, if someone's on PrEP, you would really want to know exactly how many viral particles are there? Dr. Jerome, I see you. Can you possibly field that one?
Sure. Well, we have always argued for providing quantitative results.
Quantitative results.
We believe that
there's knowledge there, and that's worth getting back to the providers. That said, I think if we're talking about screening for recurrence, this is going to be based on what the frontline providers are asking for, and there are certainly differences in cost right now, and we don't want there to be limitations of what patients can get simply because of cost, and our insistence on quantitative results. So I would actually sort of defer this one back to our clinical colleagues.
Dr. Patel, Dr. Urbina, that means you would.
Yeah, I can jump in. When you look at the data from HPTN, so the HIV prevention trials looking at cabotegravir for PrEP, they use the Abbott qualitative test, if I'm not mistaken, and the level of detection for the qualitative test was adequate. So at this point in time, if you're using it for a screener, again, I will refer to Dr. Jerome and Dr. Van Der Pol for this, but I think at the very least, if you're using it for part of these guidelines, and the guidelines specifically do not say quantitative or qualitative in a certain situation, it's either or. I think you can err on the side of the cheaper one for the population you're serving, if that's an issue. And then I'll, of course, discuss with your lab around turnaround time and ease and what's actually on your site. Some people may not actually have the qualitative because they're really an HIV testing site and they really are running more of the quantitative tests. So you can use cost as a factor and availability, but both should be fine.
Okay.
Yeah, and I would agree with that 100%, is that whichever of these molecular tests you have available and that you can incorporate into your systems is going to be fine. Now, once a test is detectable, and the patient transition to or seroconverts, then, I mean, at some point you are going to need that quantitative viral load just as a basis to monitor treatment.
Okay. Okay. I'm afraid that's all the time we have. I'd really like to thank Dr. Jerome, Dr. Patel, Dr. Urbina, and Dr. Van Der Pol, and also the sponsor of this roundtable, Hologic. And if we didn't have time to get to your question, we will try to have our experts follow up with you. And also, please look for the survey after you log out to provide your feedback. And if you missed any part of this roundtable event or would like to listen to it all again, an archived version is going to be emailed to all the attendees. And I want to just really thank these providers or these panelists. I admire you all so much, and thank you for doing the work that you do. And also thank you, audience, for joining us for this 360DX virtual roundtable event.
All right. Thank you.